professor of medicine at Université de Paris René Descartes. He works in the intensive cardiac unit at Hôpital Européen Georges Pompidou in Paris. I stress again, this is meant to be interactive, and anything you need to know, just ask, and we'll provide tips and tricks for your daily clinical practice, provided of course that we know the answers. Before handing over formally to Prof. Danchin, I have a couple of slides I wish to cover with you. And the first slide is about definition, and is the difference between guidelines and rules. So guidelines are something that is guiding you. You don't have to adhere to it. So if you're thinking that you need to deviate from that guideline in the interest of that patient, then you should do so. A rule is something different. That's a set of explicit or understood regulations that you can deviate from. And quite frequently we can mix that together. We can mix the guidelines and rules when it comes to clinical practice. As for my second slide, I wanted to talk about the classes of recommendations. So all the guidelines have got classes of recommendations. If you have a class 1 recommendation, and that's the green, then is definitely recommended and you should adopt it. If you have a class 3 recommendation, which is in red, that is definitely you shouldn't do. And then you have that gray area, or I should say the orange area, and that is divided into class 2A, where it should be considered, and class 2B, where it may be considered. So we don't have enough evidence to be sure, but it should be for A and maybe for B. And finally, when it comes to the levels of evidence, if you have level of evidence A, then it's really, really strong. Multiple randomized clinical trials have been conducted. Level B, less strong, perhaps one single randomized clinical trial or large non-randomized studies. And finally, C is a consensus of opinion. You don't have good going randomized trials to support that. So without taking any more time, you probably want to listen to Prof. Danchin and his cases, so I'm going to pass you on to him. Please.
Thank you very much, Ramzi. It's a great pleasure to be here with all of you. Thank you for attending this webinar. First of all, I must congratulate you, Ramzi, on your pronunciation of French, because René Descartes and Georges Pompidou are particularly tricky words.
I must say I was sweating there, so yes, all right.
So congratulations for this. So as you said, I will base my presentation on 2 cases. None of them are spectacular cases. They are everyday cases. And the first one is a case of a 64-year-old man who comes for a routine follow-up visit. He has a history of coronary artery disease, and he entered the disease with an anterior STEMI 3 years previously, which was treated with primary PCI and a first-generation drug-eluting stent on the mid-LAD. He had mild atherosclerosis on the right coronary artery and left circumflex, but no severe stenosis there. And his left ventricular ejection fraction, which was assessed before discharge at the time, was 50%. Diabetes mellitus was diagnosed 1 year after the acute episode and is currently treated with metformin. So the patient is still working as an engineer. He walks his dog each day for about 10 minutes. That's certainly not heavy exercise, and sometimes plays golf. He stopped smoking 3 years ago. He has no specific symptoms except that he points out that he is easily out of breath when he walks fast. He is overweight or even obese because his BMI is just over 30, with a large waist circumference of 103 centimeters. His blood pressure is 140/89 and his heart rate 72 beats per minute. Otherwise, he has a normal physical examination. His ECG is in normal sinus rhythm, no STT abnormalities, no Q waves, just a small R wave in the right precordial leads. And his current medications are atorvastatin 10 milligrams, aspirin 100, clopidogrel 75, bisoprolol 5 milligrams, and metformin 1000 BID. The blood test results, which were asked for by his GP, are those you see here. HbA1c is 7.7%, LDL cholesterol is 88 milligrams, HDL is 40 milligrams, triglycerides 143, and creatinine is normal. So I would like to address essentially 3 questions, and I will ask you to participate and give your opinion on these 3 questions. First, what would you schedule as additional workup? But also, would you change his medications? Would you insist on lifestyle modification? So first, the first question, would you schedule additional workup for this patient with an exercise test, imaging stress test, coronary CT angiography, or vascular ultrasound? Please give us your opinions on this.
So we've got around 50 seconds for this. While we are waiting, we had quite a lot of questions already, so we may have to extend the session to 9 hours.
Okay.
But the first question is, other than beta blockers, do you see any other antihypertensive drugs that can increase the risk of diabetes?
It has been described, and actually there is an association with diuretics. And the problem is to balance the potential increased risk of developing a diabetic condition and the potential benefit of the antihypertensive drugs. And there's not much question that diuretics, as beta blockers, have an adequate risk-benefit ratio in this regard, and that the efficacy they have in terms of blood pressure lowering is greater than the risk they induce of maybe developing diabetes, or it's difficult to say developing diabetes. It's actually changing from a level of glycemia to a slightly higher level of glycemia. And so it's not, we use the term diabetes because it's practical, it's useful in this way. But it's, of course, a continuum, and glycemia is a continuum.
Okay, so let's see the results of our survey. So we have quite a few people voted. So 48% will go for an exercise test, 35% imaging stress test, 11% coronary CT, and 5% vascular ultrasound.
So that's an interesting poll, because more than 8 out of 10 of you go for some kind of exercise testing or stress testing. Coronary CT angiography, I think it has no room here, because we know the patient has coronary artery disease. We don't want to have further diagnosis of this condition, and so we don't really see what we can expect from it.
Is it helpful in severity at all, in assessing severity?
It's not the best way to assess severity, especially in a patient who has a stent, because it's of course much more difficult to assess the severity of a stenosis within a stent, and it's more important to assess the presence of ischemia. So I would rule out coronary CT angiography. Vascular ultrasound is a different animal, if I may say so, because it's not to diagnose atherosclerosis. Again, here we know the patient has atherosclerosis. It's to determine whether he has stenosis on his coronary carotid arteries. So it's a different. You can do it, but you can also not do it. There's no question there. What do the guidelines say regarding exercise testing? Of course, they recommend exercise testing if there have been changes in the symptoms of the patients. And that was not the case here. the patient was really stable. He had no evidence of angina. He was a bit out of breath when walking fast, but he was very bulky, and so it's hardly surprising. In the patients who are asymptomatic, you see that the guidelines here give a grade 2B recommendation. That is, may be considered, certainly not mandatory. So I'm a bit surprised, I must say, that so many of you went for a kind of stress test in this patient. Personally, I feel that it is more important to spend some time to listen to the patient's symptoms, to ask him if there has been any difference from what he felt previously, rather than go for an exercise test. The exercise tests, either standard conventional exercise tests or imaging testing, they will document myocardial ischemia, but they won't document a plaque that may rupture a few days after the exercise test. So their prognostic value is not so great in a patient in whom you already know the coronary anatomy 3 years before. So the guidelines say that you may envisage such tests after some time, at least 2 years, but it's certainly not mandatory.
So just to clarify that, so if somebody is completely asymptomatic, you would not?
Personally, I would not.
You wouldn't.
I would not.
But you will have a low threshold for requesting it if they have new symptoms.
Exactly.
Okay.
And even if the symptoms are not really straightforward angina pectoris, it may be a change in the way the dyspnea presents or anything like this.
Okay.
So the second question is, would you change his medication?
Okay. So while we are waiting for that, I've got some more questions for you. So one of the questions is, should antidiabetic drugs be started in patients with pre-diabetes and established cardiovascular disease? What is the view of the cardiologist?
Personally, I think you have the option to start metformin, I think. Personally, I would not go for it in patients with pre-diabetes, as they already have quite a lot of medications. I would go for lifestyle modification first, rather than adding another medication. But I would be quite interested to know your opinion on
Yeah,
that.
I mean, that's why I said cardiologist. I think as a diabetologist, I 100% agree with you. I am not, I'd rather try lifestyle first, because studies have shown that lifestyle is as effective as metformin in a sense to prevent diabetes. So I'd start that first before adding in metformin. But other people may disagree. So it's an area that will need clarification, but I fully agree with your comments. So let's see the survey results. So would you change the medications? And I must say I'm slightly surprised. It's almost a 50-50.
Yeah.
58% would and 42% wouldn't.
Okay, so let's move forward. First, glycemic control. It is, of course, recommended by the guidelines that glucose lowering is instituted in a patient who has coronary artery disease. That's certain. The next question is to determine how strong you have to be in terms of glycemia lowering. And the objective of 7% HbA1c is an objective which is highly recommended to prevent microvascular disease. As for macrovascular disease, the same target is proposed by the guidelines, but with a lower level of recommendation. It should be considered a 2A recommendation, and based mostly on consensus. There is very little evidence that you should absolutely go to a low level of HbA1c to prevent macrovascular disease in these patients. And I think those data are based mostly on two large trials, which are the ACCORD and ADVANCE trial. Maybe you would like to comment on those trials, because they are more diabetologist trials than...
So, I mean, if you look at ACCORD and ADVANCE, and actually they were published the same year, both of them looked at the effect of intensive glycemic control at macrovascular complications. And they had a high risk group, so around 35% of the population had established cardiovascular disease. Now, ACCORD was stopped prematurely because there was an increased death in the intensively treated arm. ADVANCE did not show an increase in mortality, but did not show any improvement in cardio, any benefit. Now, one thing we've got to remember that in ACCORD, they reached target HbA1c very, very quickly. It was around 6 months or so, whereas ADVANCE, it took 3 years. So there was a difference at how aggressively they treated these patients. And as you would expect, there were more hypoglycemic episodes in ACCORD compared with ADVANCE. Now, whether hypoglycemia contributed to increased mortality, this has been analyzed again and again, without any concrete conclusions. I mean, I personally believe it did have a role, because you can't capture all the hypoglycemic episodes, but we don't have any firm evidence for that, and I don't know what your views are.
No, I fully concur with what you say. From a methodological standpoint, it's extremely difficult to assess the potential role of a complication such as hypoglycemia on outcomes. So, but from a common sense point of view, it really makes sense. And when you put the two trials against each other, I think that the argument you made is pretty solid, really. That is, in one case, you wanted to go fast to lower the glycemia. In the second trial, you did not. You took your time to achieve this result. And the results were quite different in terms of mortality. So I really think that the potential hypoglycemic episodes were probably deleterious. And certainly what we know is that in patients who have documented coronary artery disease, and in particular at the acute stage of myocardial infarction, hypoglycemia is certainly not a good thing at all.
Can I just say, there's one question here, that given the ACCORD trial, do we have to have a different threshold for HbA1c in people with coronary artery disease? Does it have to be higher?
It's higher than what we thought previously. And, but I think the 7% threshold is quite reasonable. And the guidelines were adopted when the results of both trials were really well known and digested, if I may say so. So I think they took into account the results of these trials. And another point which I think is of importance is that HbA1c does not reflect by itself the whole picture, and that there's a kind of, at least in observational study, a kind of U-curve between the level of HbA1c and outcomes. What's your feeling about that?
Yeah, I mean, the thing is that's quite important. I mean, this particular study here you're referring to is an observational study looking at a big population, which is always beneficial to have a big population. And what it shows that you get this U-shaped curve in terms of HbA1c and complications. If you look at on the left of the slide, so the with oral agents, the safe level of HbA1c is between 7 to 8%. If it goes below, then there's increased mortality. It goes above, there is increased mortality. In insulin users, that safe window is even smaller. It's between 7.5 and 8. Now, we've got to remember there are all sorts of caveats to this particular study, because there were people who had renal dysfunction, who were having hypos and so on. So but it just gives you that indication that low sugar is not necessarily a good thing. So I think I do like observational studies when it comes to safety, and this sends out a message, in my view. But we've got to appreciate it's got caveats in it.
And then we come to this kind of synthetic slide about the approach to glycemia And I would like you to comment it, because I think it's a very important slide.
I mean, that's we always assess glycemia with an HbA1c because it's convenient, but we've got to remember it's an average. HbA1c is simply an average, so it doesn't address hypoglycemia and it doesn't address glucose variability, and both of those have been shown to be associated with poor clinical outcome. So I think we need to slightly change our views. It's going to be very, very difficult, of course, to assess hypoglycemia properly and glucose variability, but with newer glucose devices, now we've got devices that can measure 24-hour glucose much easier than before. That should be something that perhaps we need to concentrate on. Can I just say there's one question that came in, I think it's from the same person, regarding what we said about metformin, not to use metformin. This person says that, so what would you do? You implemented diet and exercise, but the still dysglycemic, this person, not in the diabetic range, but dysglycemic. What would you do then? Would you not give metformin?
Personally, I would not.
Yeah. I mean, I completely agree with that.
So the beyond glycemia, of course, there are the other parts of the picture, and in particular blood pressure control. And the story here is not so different from what was found with a glycemia. And indeed, we have seen the guidelines change over the past 10 years. And the target blood pressure, as you see here in green, the second row here, is less than 140 over 85 millimeters of mercury. And I think that is an important change from what we expected before and what we suggested before in the previous guidelines, where the targets were lower, actually. And the second important point is that among the medications which are recommended, it is recommended to use a renin-angiotensin system inhibitor, either an ACE inhibitor or an ARB. And it is also contraindicated, or there is a red flag for the combination of ACE inhibitors and ARBs because of the risk of adverse events, and particularly hyperkalemia. So in this patient, the blood pressure is 140 over 89, which is probably a bit too high, so we should try and do a bit better. The patient is treated with bisoprolol and not by an ACE inhibitor, and I think he should receive an ACE inhibitor. So I would probably change the bisoprolol or add an ACE inhibitor rather than leave the bisoprolol alone. And I would definitely opt for an ACE inhibitor or an ARB as the first-line therapy for his hypertension. The basis for these recommendations also come from the ACCORD trial, mostly from the ACCORD trial, because it was a factorial design in this trial. And there was also then a question about blood pressure with two arms, one where the target was less than 120, and the other one was more conventional, less than 140. And as you see here, there were actually more deaths, even though it was not statistically significant. There were actually numerically more deaths in the lower target arm for blood pressure. And that forms the basis for the current recommendations. Sometimes the better is enemy from the good. And so it's always a problem and a risk of adverse event when you pile up medications and never stop doing that. So I think we have to be reasonable and try not.
Do you think there's a similar story to HbA1c, that lower is not always better?
It's rather well demonstrated for diastolic blood pressure, particularly in coronary artery disease patients, because as you know, myocardial perfusion happens mostly during diastole. And so if you have a lower diastolic blood pressure, it's probably not so good for myocardial perfusion. And the observation studies or observations from randomized trials show that there is a kind of J-shape or U-shape association between diastolic blood pressure and coronary events. So we've seen glycemia, we've seen blood pressure. What about lipids? It's probably a bit easier. All of these patients with coronary artery disease and diabetes should have statin treatment, unless they are intolerant to statins, of course. The rules do not differ in a coronary artery disease patient according to whether he or she has diabetes or not. That is, this is a very high-risk patient. We have to give statins, and we have to try to achieve rather low levels of LDL cholesterol. The current target suggested by the European guidelines is 70 milligrams per deciliter. In this patient, he has a rather low dose of atorvastatin, 10 milligrams. I would really suggest to increase the dose of atorvastatin to try and achieve an LDL level lower than the 88 milligrams per deciliter that he currently has.
While we're on the statins, there's a question that came in regarding statins and diabetes in the non-diabetes group when you treat them. Is there a difference between the different statins in terms of predisposition to diabetes?
Yes and no, I would say. It seems that what counts really is the intensity of statin treatment and of LDL lowering with statins. It will be quite interesting to look at the diabetic status and glycemic status in the patients who receive newer lipid-lowering medications such as PCSK9 inhibitors, which are, of course, very powerful lipid-lowering medications. But here with statins, it's clear that the more potent statins carry a higher risk of developing diabetes than the less powerful
Pravastatin and so on.
Yeah. Yeah.
Okay.
So we've seen glycemia, we've seen blood pressure, we've seen statins. What about antiplatelet therapy? We have a patient 3 years after implantation of a drug-eluting stent for a STEMI who is still on dual antiplatelet therapy with aspirin and clopidogrel. And that is indeed strange, because the guidelines are quite clear. After an acute coronary syndrome, STEMI or non-STEMI, dual antiplatelet therapy is recommended for 1 year. And after implantation of a drug-eluting stent in a stable patient, that was not his case, but in a stable patient, the current recommendations, the very recent one, which were published just 1 month ago, these recommendations suggest to give dual antiplatelet therapy for 6 months, which is much shorter than what we thought initially. But anyway, none of the recommendations suggest that we should prolong treatment beyond 1 year. This might change in the future because we're awaiting very important clinical trials on the duration of dual antiplatelet therapy in the coming weeks and coming months. So that may change in the future, but for now on, I think it's not reasonable to maintain dual antiplatelet therapy in such a patient, even in a patient with a first-generation drug-eluting stent, as was the case here.
So which antiplatelet would you stop?
Would
you continue?
I would probably maintain aspirin and stop clopidogrel. However, I think it's an interesting question, and it's not from your part an innocent question at all.
Not innocent at all, no.
That is because the diabetic patients, the platelets, we know that there is a problem with the platelets in diabetic patients, and we don't exactly know the best antiplatelet agent in diabetic patients from my point of view. I don't know what's your feeling.
I mean,
would you go for clopidogrel rather than?
there is some very weak evidence that clopidogrel is better than aspirin, but it's very, very weak evidence. I think aspirin doesn't work that well in diabetes. It may work better if you use it using a different regime, but we haven't got any clinical data on that. I still think that aspirin is important because it is the only agent that inhibits that particular pathway, the thromboxane pathway. It's not like the P2Y12, you have different agents to use. So the clear-cut answer is I do not know because we haven't got the studies, but definitely the effect of aspirin is sort of reduced in patients with diabetes, and it's something that needs to be looked into.
It's a question that is currently addressed in some trials.
Correct.
There is a trial called
Yeah.
CEMIS, which is ongoing, specifically in diabetic patients with coronary artery disease. I think we will have some kind of answer to this question in the future, but we still have to wait a bit. The last point and last question for this case is, would you insist on lifestyle modification? So you can vote.
So while we are waiting, so we had again some interesting questions. One of the questions, there were two questions about glycemia in ACS. One is, what sort of levels of glycemic control you'll be looking for, particularly to avoid hypoglycemia? And the second question was, if the patient cannot tolerate metformin, what would you use instead?
For the first question, we will deal with that in the second case. However, I can give already a brief answer. It is not recommended at the acute stage of an MI, of an acute coronary syndrome, to use insulin if the glycemia level is not above 180 milligrams, which is 10 millimoles. And I think that's an important point. As to the second question, I turn to you.
As for metformin question, I mean, in my experience, you need to try to give metformin. You can start with a smaller dose and build it up, or if you're struggling, you can give metformin MR or SR, wherever, which country you're in, because the extended release metformin is associated with very little side effects. As for the other drugs, I mean, it depends. I mean, when it comes to the gliptins, we've got a study on saxagliptin showing that it's neutral when it comes to cardiovascular disease, but it may, and I stress may, increase heart failure. GLP-1 analogues, there was a question about that as well. Studies are awaited when it comes to cardiovascular and GLP-1, so we'll see what happens there. But I would push personally for metformin.
And what about sulfonylureas, older drugs? Because there has been an interrogation in the past as to their safety, and particularly in the context of acute myocardial infarction.
I mean, there are a number of publications. There's a very recent one, a meta-analysis of more than 1 million patients showing that there's an increased risk of cardiovascular death with sulfonylurea. It's a drug that's been with us for a long time. We know about the side effects. Quite possibly, this increased cardiovascular mortality is related to the hypoglycemic effect of the drug. Could be something else, I don't know. But this is an area that requires looking into in a little bit more detail. And you know, I always say this, that previously meta-analysis of less than 30,000 patients resulted in a drug getting withdrawn from the market. So I think we need to look into these data in great detail.
And do you feel that there may be differences between the type of sulfonylureas, mainly glibenclamide on the one side and the more recent ones on the other side?
Absolutely.
Because glibenclamide is known to prevent myocardial preconditioning in case of ischemia and may have a specific deleterious effect in this regard.
Yeah, absolutely. I think the newer sulfonylureas are certainly safer, but they are perhaps not as safe as metformin. And of course, the argument always is metformin cardioprotective and sulfonylurea is neutral, or is it that sulfonylurea is harmful? So it's quite a difficult question, and I don't think we will have a proper RCT to answer it, because who's going to fund that? So I think it's just something that we need to be careful about. I'm not saying we shouldn't use sulfonylurea. I think they've got a rule, but we've got to be careful with their use. So let's just see the results of this survey. Now, this was an easy one, actually. 99% for a yes and 1% for a no.
Okay, that's hardly surprising. I'm glad there is one no, because that means that not everybody thinks it's easy to obtain, to achieve lifestyle modifications in our patients, and even in ourselves, I should say. If you look at the guidelines, you see green everywhere, and you see dark blue everywhere, which means it's a very high level of evidence. It's level A. So there is really an incredible amount of evidence that lifestyle modification, when possible, improves outcomes in diabetic patients, and particularly in patients who have diabetes and coronary artery disease. It holds true, of course, for smoking cessation, and is possibly more important still in diabetic patients compared with non-diabetic patients. But it's true also for diet and for exercise. Exercise is certainly an extremely important part of lifestyle modification in all coronary artery disease patients, but specifically, I think, also in diabetic patients. And I would just like to show you the long-term results of the Steno trial. It was a very small-sized trial, but perfectly performed, and the multifactorial approach resulted in very fast differences in terms of cardiovascular events. But as you see here on the left side of the slide, after a few years, there was even a difference in terms of mortality. So lifestyle modification, and particularly a multifactorial lifestyle modification, is in fact beneficial in terms of cardiovascular events, but also in the long term in terms of prevention of cardiovascular death, which means increasing life expectancy in these patients. So I think it's not only incantatory, the plea for lifestyle modification, but I think we should take time to try and implement it, knowing that it's not easy, and maybe the GPs or the specialists are not always the best persons to really convince the patients, but I think we should at least try to do so and explain the importance of that to our patients.
I think that you're making a very good point, that it is time consuming, but it is important. Yeah. It is very important. While we're on the issue of exercise, there was a question about what about HDL?
HDL cholesterol, there are several ways to increase HDL cholesterol. Medications, we've tested those, it doesn't work. It works on HDL levels, but it does not work in terms of clinical event prevention. So we are left with the two other ways. One is alcohol, which increases HDL cholesterol. It seems that mild alcohol consumption may have benefits in terms of cardiovascular prevention, but certainly not heavy consumption. And the other method to increase HDL cholesterol is precisely exercise. You have to have a rather high level of exercise to really increase your HDL cholesterol, but it works. And so I think it's very important as well in this regard. So it may be one of the means by which exercise is beneficial.
There was another question about aspirin. Would you advocate using aspirin for primary prevention in diabetes?
Not for, I would say, the general population of diabetic patients, because it doesn't seem that we have enough evidence. It doesn't seem to me that we have enough evidence to that the prescription of aspirin will outweigh the potential side effects which are present in diabetic patients as in non-diabetic patients in terms of bleeding, gastrointestinal effects and so on. So personally, I would be rather restrictive. as to the use of aspirin in primary prevention for diabetic patients. But in high-risk diabetic patients, it might be worthwhile, yes.
But that's quite elastic, isn't it?
Yeah,
What is
yes,
high
it is,
risk?
it is.
One thing to remember that in lower risk patients, you need to treat number needed to treat is around 3,000 to get a benefit, and 1 in 450 will bleed.
Yeah.
So the risk-benefit ratio is just not right.
Yeah.
Right. I think perhaps we can move on to the next
So
case.
the next case is a case of an acute coronary syndrome in a patient who had previously undiagnosed diabetes. It's a 69-year-old woman who presents with recurrent chest pain at rest, quite suggestive of angina pectoris. She is admitted to the intensive care unit. Her personal history: she has never smoked, she is treated for mild hypertension and has been treated for about 5 years with an ARB. She is retired. Her physical examination is unremarkable. She has a normal BMI. Her blood pressure is 136/83, her heart rate 75 beats per minute. Nothing much remarkable there. What is more remarkable is her ECG that you see here. There are huge T-wave changes here in the precordial leads and even in the inferior leads. Her level of troponin is elevated. Her glycemia is 150 milligrams per deciliter, and her creatinine is normal. As a second step, she had a measurement of HbA1c, which was 7.2%. Her LDL cholesterol on admission was 110 milligrams per deciliter, HDL 44, and triglycerides 125. So my question here is, would you consider this patient to have diabetes? Yes, no, or would you need further investigation to decide whether she has diabetes or not?
So while we're waiting for that, I've got 2 questions on lipids. One is, does ezetimibe have any good effects? And 2, if somebody's got mixed hyperlipidemia, do you have a preferred statin to use?
For the second question first, I don't really have a preferred statin for mixed hyperlipidemia. There might be slight differences among statins, but I do not have a very strong feeling about that personally. I would most probably go for one of the 2 more potent statins, which are atorvastatin or rosuvastatin in these patients, because I think we will need to lower the LDL level quite much. As for ezetimibe, we know it works on LDL cholesterol. There's no question about that. What we lack is definite proof that it is efficacious in terms of cardiovascular event prevention. And we will have very soon, actually, we will have the results of the Improve It trial, which will bring a piece of evidence in one way or the other on the use of ezetimibe. I'm not certain it will resolve all issues anyway, but I think we will have more information there. But I think at present we have little information on the effect of ezetimibe on cardiovascular events. We know it's quite potent when added to a statin in terms of lipid lowering. Yeah.
Okay, so let's just see the survey results. So, interesting, you will like this. So the yes is 55%, no is 1%, and needs further investigations is 44%.
Yeah.
So it's all half-half. So
I would be interested to know if the no is the same one that has advocated no change in lifestyle for the...
I don't think our software can do that.
Okay. No, that's an interesting question, and I think you are probably the best person to answer this question.
I'm not sure I'm the best person, but I'll try my best. So I think The guidelines say that if we have an HbA1c above 6.5% or 48 millimole per mole, particularly in the presence of symptoms, then you can make a diagnosis of diabetes. Now, personally, in my practice, I supplement that with the fasting glucose as well to be absolutely sure. The false positive is less common than the false negative. The false negative, you've got to be slightly, so I get slightly concerned about things like type 1 diabetes, for instance, people who had diabetes for a short period of time, then HbA1c may not rise that quickly and you can miss the diagnosis. But generally speaking, I think if it is above 6.5 in a patient who just had a coronary event, then we are probably dealing with diabetes, particularly if you have a high random glucose or a high fasting glucose. I'll be quite comfortable with that. Things get a little bit more difficult when it is in the grey area, so less than 6.5 but not normal. What do you do then? And there were quite a lot of questions on that. And I think that is an area where the glucose tolerance test still will have a role. So it's a lot less than before. We are using it. I mean, I use the glucose tolerance test a lot less than previously. It's very, very rare when I need to use it because most of the time you can make a diagnosis with HbA1c and fasting glucose. I don't know whether...
No, I think that most of cardiologists don't use it at all.
At all. The glucose tolerance test, yes. No.
But you agree with me that glycemia alone in this particular context would not be sufficient to diagnose diabetes?
What, hyperglycemia without a rise in HbA1c? Yes. So if the HbA1c is normal and they've got high...
So it makes sense to measure HbA1c in this context.
In this particular patient, we've got two numbers that are high. So I'm quite comfortable with the diagnosis of diabetes.
I would be also. So I would not need further workup for this, but I don't think it's bad to envisage something else either. So what do the guidelines say in terms of glycemic control in patients with acute coronary syndrome? We come back to the question we tackled previously on the requirement or the possibility to use insulin, and you see that it's a grade 2A recommendation, but level of evidence C, to use insulin in patients who have very high levels of glycemia at the time of their acute coronary syndrome. And I think that is important to keep in mind. You should not completely discard the use of insulin in these patients. And we have sometimes patients who have very, very high levels of glycemia at the acute stage of an MI. And I think that it's absolutely useful to have insulin in those patients. Then we have the question of the initial strategy in terms of invasive versus non-invasive strategy, and that is quite straightforward. And it's not different in diabetic or non-diabetic patients. If you have a primary criterion for high risk, you should go for an invasive strategy, and depending on the type of criteria you will have, you may go for an early invasive strategy, that is within 24 hours, or a slightly delayed within 3 days of admission invasive strategy. So in this patient who had troponin, increased troponin levels plus STT abnormalities, I think we had a very good reason to perform relatively rapid coronary angiography, that is within 24 hours. Urgent coronary angiography within 2 hours is meant to be used only in persons who have high levels of instability, be it hemodynamic, rhythmic, or repeated episodes of chest pain. So that was not the case in this patient, but I think that early invasive strategy within 24 hours would be warranted in such a patient. As for antiplatelet therapy, I will be quick because it does not differ from non-diabetic patients. You have to use both aspirin and a P2Y12 inhibitor. And among P2Y12 inhibitors, you have to have a preference for ticagrelor or prasugrel compared with clopidogrel based on the results of the Plato and Triton trials in these patients who will undergo an invasive strategy. So here are the results of the coronary angiogram. I will describe them briefly. On the right, you see the right coronary artery, which is quite big and has a very tight stenosis on the mid-segment of the right coronary artery. And on the left, you have very extensive disease with a stenosis of the left main, stenosis of the second marginal branch of the circumflex, and two stenosis. It's maybe a bit difficult to see here. Two stenosis on the LAD, one on the proximal part of the LAD and one on the mid part of the LAD. If you calculate the syntax score, it's calculated to 27 in this patient. So there's the question of the use of metformin in these patients who undergo coronary angiography. In the past, it was more or less recommended to stop metformin at the time of coronary angiography, and the guidelines have really changed in this regard. And now it is quite accepted to perform coronary angiography, especially in an emergency context like this one, without stopping metformin. And you should certainly not delay coronary angiography because the patient would be on metformin. The only thing is that you should carefully monitor creatinine after the coronary angiogram. And if there is no problem there, you can continue metformin. If you observe a change in creatinine, then you should stop.
So when would you repeat the creatinine after the angio? How soon?
Certainly the day after and 2 days after, I would also.
So if in 24 hours it didn't change, would you be happy to start metformin early, less than 48 hours?
Yeah. Especially if it was completely normal before. If you are a bit of in between mild renal failure and normal renal function, then you might wait a bit. So what would you propose now in terms of myocardial revascularization? Would you propose optimal medical therapy alone, PCI with a BMS, PCI with a drug-eluting stent, CABG, or you don't know?
Okay. So while we're waiting for the results of that one, there's a question that came in. If somebody's got typical chest pain, diabetes patient, typical chest pain, but troponin negative, what would be your diagnosis? They've got typical...
unstable angina in such a case.
Yeah.
It's becoming a rare diagnosis with high sensitive troponins. It's very rare to have unstable angina. You have either stable angina or non-ST elevation myocardial infarction because the high sensitivity troponins are often elevated in those patients.
Okay. There was another question that came in about gliptins and cardiovascular. What do we think?
That's for you.
Well, I mean, the evidence that we've got at the moment that they are neutral. There have been 2 studies conducted in that respect. They are neutral, but there is a signal of increased heart failure, but we don't know at this stage whether that's real. So we need to keep a close eye on that. So we've got only 3-4 minutes left. So let's just see what this survey shows. Optimal medical therapy alone, 5%. PCI with a bare metal stent is 10%, and then with drug-eluting stent 26%, and CABG 59%.
Good. So I personally...
And can I just say this?
Yes.
No one said I don't know.
Okay, good.
That's important.
I'm quite happy with these results, and I do agree with the majority of our colleagues here. And when we look at the guidelines, there is little question that coronary bypass grafting in diabetic patients with multi-vessel coronary artery disease should be the kind of default strategy. And only in selected cases you should go for PCI, and then preferably with a drug-eluting stent or drug-eluting stents. So those are the guidelines as you see here. And those guidelines are based on several kinds of data. First, the initial trials comparing PCI and coronary bypass grafting. Most of these trials did not use drug-eluting stents, but in the individual meta-analysis of the individual data of these first trials, published by Mark Latke in 2009, you see here the two upper curves, and in the upper part of the slide, those are diabetic patients treated with PCI, the top curve, or treated with coronary bypass grafting, the second upper curve. And you see that there is a huge difference here in favor of coronary bypass. Then there has been the FREEDOM trial, specifically in a diabetic population, which again showed a benefit of coronary bypass grafting compared with PCI in terms of cardiovascular events and even in terms of mortality. And finally, we have the analysis of the diabetic subgroup in the SYNTAX trial, which compared coronary bypass grafting with PCI with a first generation drug-eluting stent, the Taxus stent, in patients with really severe coronary artery disease, multi-vessel coronary artery disease. And you have here the results at 1 year in diabetic patients on the left and in non-diabetic patients on the right. And you see here that in terms of MACE, the patients treated with coronary bypass did much, much better. That was not true in terms of death, cardiovascular, stroke, or myocardial infarction, which was equivalent at 1 year. But we have just had the 5-year results published in the European Heart Journal. And you see here how the landscape differs at 5 years. At 5 years, even all-cause mortality is double in the PCI group in those diabetic patients compared with the coronary bypass group. And it is also true for MI, repeat revascularization, composite, etc. So you see that there is no question that coronary bypass surgery is preferable to drug-eluting stents in these patients.
I think we are running out of time. I think this 1 hour has flown by. So in conclusion, I really don't know about you, but I found this to be of great, absolutely great learning experience for me. I mean, we have covered various areas in the management of dysglycemic patients with coronary artery disease. Hopefully, we have provided some answers, and perhaps we created a lot of questions actually in the process. Thank you for the excellent contribution, and I'm sorry if we could not answer all the questions. It certainly made the session particularly exciting. I would like to thank you again, Nicola, for the great cases, for preparing them, for taking us through them, and for addressing all the different guidelines and the questions. Finally, we both would like to thank the European Society for Cardiology for arranging this webinar, which we hope was useful. We are particularly interested in your views and feedback, so it'd be really nice if we can have your feedback on how we can improve these webinars. So thank you very much again, and all the best. Bye-bye.